Hello, Sylvia. Can you hear me?
Yes, I could hear you now.
Okay, that's good. Oh, finally.
How you been? Good?
I've been doing good. How about you guys?
Yeah, first week, so we'll see how it goes.
Have you had your first quiz yet?
I have mine on Saturday.
Okay. Okay, sounds good. Okay, so you guys are doing probably geriatric.
Yeah, geriatrics and cancer.
Uh-huh. Yeah, interesting topic, right? So do you have any questions so we can start the tutoring?
Yeah, hold on, let me get my notes.
Okay, sure. Let me get mine too.
Hey, Sukhraj.
Hello, can you hear me now?
Yes.
Pretty good.
How you doing? How are you doing? I haven't seen you since Pauline's class.
All right. Yeah, Vanessa. Now I remember you.
Look at you. You're ahead now. You're almost done.
Well, not almost, but a year. But yeah, so far.
Yeah, you're closer than me.
There's one class behind me.
Yeah, you're an LVN, right?
Yes, I am.
Yeah. All right. We're gonna learn from you today. I'm excited.
Good. I hope I can teach you something.
Oh yeah.
Well, not teach you, but help you get through the program.
Thank you.
So, do you guys have you had your quiz yet?
No, I'm in the same class as Sylvia. Not until Saturday. Tomorrow. Yeah.
Okay. And we have a real. I think I mispronounced it.
No, you're fine. Yeah, Ariel. My quiz is today.
Oh, what time?
I have it at 12:30.
12:30. Okay. So, are you prepared?
I feel prepared, yeah, so I just wanted to use this as a review. Overall, yeah, I mean, I don't know, it's the first quiz, so it's like, I don't know, this is where I find out pretty much how to really study.
Yes. Yeah. So how you guys have been studying for this class?
So my professor, her name's Khan. I went over her lecture, her PowerPoints, and then I thoroughly read, in the book, anything I needed clarification on, or just anything I felt like I needed to go in depth.
Right. Okay. So are you guys reading the ATA book?
No, I didn't. I haven't even looked at the ATA. I only read the book and the PowerPoint and hear her lectures like 2-3 times.
Yeah. Yeah. The ATA book, I think that's the really good book. It has almost everything in a condensed form that we need to know. But I think you guys should read that before the quiz and everything. And it's kind of a review after you studied, and then if you want to review, go to the ATA book and read it and ask yourself questions. And then we do have the adaptive quizzes. You can select the topic and do that quizzes as well. For ATA book, yes, I do recommend. Every time I studied, my scores were better. So, any questions about the topic? So, are you guys all in the first quiz right now, right? Anybody has taken the first quiz yet? Jolene? Okay. So if you guys have any questions about the topic, the cancer and geriatric, we can get started. Okay. Okay, so no questions? Okay, so I'm gonna ask you some questions about cancer. Um, what is the number one type of cancer that affects males? Yes, and the female? And the second highest type of cancer in both genders? Lungs, yes, lungs. The colon is the third one. Do you guys know what type of genes or genes are found in ovarian cancer? How you get tested for ovarian cancer? Yes, pap smear, that's how we get tested and also to prevent it. But what kind of gene tells us, yes, that one, that's the one. I think it's also for the breast cancer. I'm looking for it, but I can't find so far. Yes. Mhm. Okay, so what are the viral carcinogens that we need to be aware of? Viral. Yes, those are the carcinogens like we need to be aware of, but what were the viral carcinogens? Mhm. Okay, so the virus that can lead to cancer is ABV, HIV. They're like specific cancer associated with the HIV, Kaposi sarcoma. Yeah. And then there's, HPV virus that we need to be like, be aware of that it can lead to cancer if it's left untreated. And then hepatitis B virus as well. But yeah, yes. Mm-hmm. Okay, so how do we know that the treatment is working? Yes, but there's a like specific test that they do in the cancer, with which we know the treatment is working. Do you remember? It's a type of an antigen. Okay. So that one is CEA. Let me know. Let me see the full name. Carcinoembryonic antigen, and if the number of this antigen is reducing, that means the treatment is working. Do you guys remember how we do the staging and how we do the grading? Okay. So can anybody tell me what is the grade 1? How many grades are there though? 4, yes. And how many stages are there? Stage 2, limited local. I was just asking how many stages do we have in the cancer? Like, yeah, 4, but if we include 0, then that's 5. Grades are actually 4, that's grade X, like grade cannot be assessed on that one. So it's only 4 grades, but the last one is like we cannot assess the grade. And with the cancer, there's one more thing, like once the stage has been decided, the patient is gonna, maybe they can progress, but if the cancer is decreasing, we are not gonna decrease the number of the stage. Like we cannot say the patient was in grade 2, but now the patient is in grade 1. Sorry, the patient was in stage 2, but now the patient is in stage 1. If a doctor mentioned that like the patient is in stage 2, the patient is gonna stay in stage 2. We are not gonna decrease the stage, even if the cancer is getting better. I hope that makes sense. Did I confuse you guys?
So regardless, so if the patient's cancer is getting better, you said the grade doesn't change?
I'm talking about the stage, not the
Oh, the
grade.
stage. Okay, okay. Yeah, okay, that makes sense. Thank you.
Yeah. So there are 2 type of staging classification. We do it with clinically and surgically. Do you know how we test the stage clinically? What are the tests that we do to figure out the stage clinically? You know this? I'm pretty sure you know this. Yes, it's a TMN, but like, what are the tests that we do to figure out the clinical stage? TMN is like a parameter, like tumor size, spread up to the lymph nodes and then metastasize. So, but how do we figure out like all that? Yes, biopsy could be one. What are the other ones? Mm-hmm. What type of scans? Yes, MRI, CT scan, PET scan. Mm-hmm. Maybe ultrasounds. And if it's a liver cancer, then we do the liver scan. I think. Okay. So let's go over what nurses do regarding cancer. If the patient is experiencing fear and anxiety, how do we communicate with the person? Yes. But before we go to the patient's room, we need to know how, as a nurse, I'm feeling about the cancer. We need to know our own feelings. We need to aware how we're gonna feel when if we are in that person's situation. So all that, manage your own discomfort before you talk to a patient. That's very important. But yes, actively listening and encouraging the verbalization. Yes. Yeah, basically we need to make them comfortable, give a clear explanation, and avoid a communication pattern that may hinder exploration of the feeling. Like with the patient, most of the patient, they don't know like what's benign and malignant. So they may confuse between those two type of cancers. But we need to like tell them in their own very simple language so they don't get confused. And even if the cancer is malignant, if we're talking about any treatment or anything, if we are doing anything with them, try to use the simple language other than the technical language. Okay, so how do we prevent cancer? What is dysplasia? Yes. Hold on. Before I tell you that, let me make sure because I want to be clear on that. Okay, so dysplasia is decreased or increased number of the cells. But hold on. Yes. Anytime we see any change, any changes in the number of the cells, any increase or any anything like that, any abnormal development in the cells or the tissues, we say that it's a dysplasia. It could be cancer. Um, so the number one stage, the grade that we say is the mild dysplasia, that there's a abnormal, little bit abnormal number of or development of the tissues. That's what we say like it's grade one because you have a mild dysplasia. So in dysplasia, the cells looks different than the normal cells. Okay, so how do we prevent cancer? Yes, recommend checkup, avoid carcinogens. Yes, and 7 warnings signs of a cancer. Mm-hmm. Yes. If I follow word caution, so it's easier to remember all the warning signs of the cancer, like change in bowel or bladder habits, a sore that does not heal, unusual bleeding and discharge, and then thickening or lump in a breast, indigestion and difficulty in swallowing, obvious change in a mole, nagging cough or hoarseness. So those are all the warning signs of that it could be cancer. It does not mean that it's going to be cancer, but it could be cancer. Okay, so let me pull up my other notes. Where are they? Okay, so let's say a person is saying that I have a benign cancer, but doctor is telling me that I need a surgery or something. What would you say to that person? Or let's say a person says like, I have a benign cancer, but and they feel really very very scared and anxious. What are you gonna How are you gonna communicate with this person, and what are you gonna say to them? Anybody?
I'm just gonna guess. Would you tell them that the benign tumor could turn into a malignant one? That's just
Yes,
like,
but benign is not a cancer.
right.
Yeah, so that's the first of all, like we need to tell them like, hey, you have
Oh, okay, okay.
benign, so it's not a cancer yet.
Oh, okay. So explain basically that
Yeah, because
it's not yeah, that it's not cancer, that it's not a bad, necessarily a bad thing.
yes.
Okay.
Yeah, because most people will get confused with malignant and benign. I was confused before I took this class. So people don't know, like, benign or malignant. That's like a medical term, I would say, but I think most of people, they don't know. So it's always go back to the basics. So any question that you might have that I forget to go over with cancer? Oh yes, we always want to encourage them to communicate in any type of treatment or with any type of disease. Yes. Cancer treatment. Yes. So there are different type of cancer treatment. Some could be to cure the cancer. Some could be to control the cancer. And the other like a palliative care with the cancer. If they have no response to initial treatment, then we go to the palliative care. So the cure could be like, surgical chemotherapy, any radiation therapy. So anything like that that could reduce the size or cure the cancer. Um, that's the first treatment, and then we try to control it, minimize the size and minimize the cancer from metastasizing. So we want to basically, what we do is try to control it, like it stay where it is and it does not go further in the body. For that, it's basically it's the same, but they're like different nursing intervention that we do. So for control, we do the maintenance initial course and then maintenance therapy. And our goal is to try to maintain the cancer wherever it is right now for a long period with the therapy. Then if the cancer does not cure or we cannot control it, and then our main goal is to relieve and control the symptoms and maintain the satisfactory quality of life. We want to prevent, like pain management is the most important in that case. Nausea, vomiting, we want to control that as well. Anything that I forget?
No, you're doing good. Thanks.
Anything else that you want to add in that?
So also for complications and adverse effects of chemotherapy,
Mhm.
like the complications for chemotherapy.
Okay, so just a moment, because she's asking me for the code. I'm gonna share it again, but I don't know. Like it says it's anatomy code, so I'm
Yeah,
gonna
it's
share.
anatomy. It says anatomy. So I filled it out in either way, and I put your.
Okay, sounds good. Let me share the screen one more time so she can get the code.
Got it. Thank you, Sukhraj, for everything. I'll see you next Friday.
Sure. Take care. Bye bye.
See you tomorrow.
Okay, so your question was with the chemotherapy, right? Can you repeat it,
Yes.
please? Can you repeat one more time?
So complications, adverse effects of chemotherapy. Would that be like bone marrow suppression, like the white blood cells, platelets, red blood cells?
Yes,
Right.
the chemotherapy is gonna suppress the immune system. So whatever we do with the tell the family not to bring any fresh flowers or fruit, or and not to go into the crowded area, and that's all to prevent them from developing further complications like infections and stuff. And chemotherapy is gonna be systematical. It's gonna affect their whole body. It's not gonna be like radiation therapy on which goes on like a single single space, like single, how we call it, like on a designated area. But chemotherapy is like everywhere. It goes everywhere, whole body. So it's gonna make the person weak physically, and nausea, vomiting, and then risk for infection.
Okay, thank you. What do you think we should focus more and more on, like for the exam or the quiz?
I would say we need to know the pathophysiology, but in this case, it's when we talk about dysplasia, the normal cells versus the abnormal cells. That's what we need to know, but that's more in the pathophysiology. So for anything in the med search, focus on the sign and symptoms, focus on the nursing interventions, patient teaching. So that's the MedSurg is all about the nursing intervention, patient teaching, and then this learning about the disease, like how we're gonna figure it out. Basically, the sign and symptoms. I had a Dr. Poi Yamada. I don't think she's teaching at our university anymore. Okay, so the chemotherapy. We were talking about the chemotherapy, right? So they have chemotherapy does not go into the peripheral IV. They always have to have a catheter in the there's a specific type of catheter. I forgot the name, but it goes into their right here in the neck, but I forgot the main name also, sorry. But we cannot give the chemotherapy via peripheral IV. It's gonna cause extravasation. Portacath, yes, but there's a specific name for that. Um, yeah, I don't remember the name, but maybe I wrote it down somewhere. Yeah, if I find it, I will let you know. But for right now, yeah. So the extravasation, because if we start the chemotherapy in the peripheral IV, it's gonna cause pain, swelling, redness, vesicles on skin. After a few days, it may cause necrosis, and then a person might lose the limb, because it's very dangerous for the surrounding tissue, and we don't want to give it via any peripheral IV. And the complications with all that is sepsis, scarring, contracture, joint pain, and nerve loss. So it also says may need surgical interventions from debridement to skin grafting. So if anything like that happen, the first thing that we want to do is turn off the infusion immediately. Okay, so CVAD, that's what they call it. That's how we administer um, chemotherapy. So it's placed in the large blood vessel. Oh, I forgot that again. Sorry, mind that. Cephalic, maybe? But we do have that bigger vein right here. I think my mind is not working right now. Sorry, I'm forgetting things. Okay, so chemotherapy affects on the normal tissue as well as the cancer tissue. It does not know how to distinguish between normal and abnormal cells. So the side of effects could be result in the destruction of normal cells, reduce platelet numbers. It could cause the damage to the heart as well. So what are the other effects that chemotherapy can have on a patient, other than that we already talked about? Yes, GI, but anything else? Yes. What is the biggest one with anything that we do, like any type of drug? Yes, hypersensitivity. It can also cause some cardiac dysarrhythmia and bone marrow suppression. For the long term, if the person is on chemotherapy for a longer period of time, then organ damage can also occur. Okay, so let's talk about any question on the chemotherapy though? Okay. Okay, so how about the radiation therapy? Where did it go? Okay. So how often the radiation treatment is given? Penias, you mean the thrombocytopenia, leukopenia? Yes, especially chemotherapy, radiation therapy is like designated to a single part of the body. It's where the cancer is. It's not going to go systematically. So for chemotherapy, yes. Okay, so what are the things that we need to know about radiation therapy? Anything?
Let me just put my mic on so I can, it's easier. So for radiation, it's used in combination with something else, right? Like medication and then a radiation.
It could be.
Okay.
Uh-huh.
Okay, so
Um,
it may be used by itself or in combination with something else, right?
it could be, yes.
Okay.
hmm but there's a number one important thing that we need to know, because radiation therapy, like I said, it's designated to particular area of the body. So what they do is they make a small outline where they need to focus the radiation therapy on. So tell the patient not to wash it,
Okay.
not to remove the outlining, the tattoo that they put it on, because that's where, like, because it's every single day for 5 days a week. So we need that tattoo to figure out that where the radiation therapy is going to go.
And so I saw something on ATI that said a person is just supposed to use lotion, and then another one said they can use lotion. So I'm confused. Do they use or don't use at all?
Okay. So about that, I know that they are not supposed to use, like, rub the area, and it can cause, like, very like dry. I think I'm gonna pronounce it really wrong. Desquamation. I don't know. Yeah. So for that, we can always lubricate it, because it's gonna be very, very red and dry skin.
Okay.
So we can always use the any kind of lotion on it. Make sure that does not contain any alcohol, perfume, or any additive. Um, Aloe vera is the best because it's very natural if it comes directly from the plant. But they need to put lotion on the area, because it can lead to skin breakdown.
Okay.
Yeah. And then there's, like, another problem that we can have is the wet. One is dry, other one is wet. So for the wet, the goal is to prevent infections and facilitate the wound healing. And we also need to protect these two from the extreme temperatures. Don't use any heating pad, ice packs. And we, like I said, we always want to avoid any constricting garments, rubbing, harsh chemicals, deodorants. It will cause pain, drainage, and increase the risk of infection.
So is this for both of them, the dry and wet?
So the last one that I said, that the pain drainage, that's for wet.
Okay.
It can also cause pain, but it depends on person. But
So,
dry is like more irritation. It's uncomfortable. It's like pruritus.
okay.
It's very uncomfortable for the person. There is no drainage or anything. They will have a severe redness, but in the wet they will have the drainage also. Wet looks like basically like a wound, it's closed wound or something like that, but it's gonna have a drainage.
So so the dry one is why you would use kind of the lotion without the alcohol and everything, just to keep the skin.
So the lotion without the alcohol, perfume, and everything is for both.
Okay.
I would not use any lotion. It does not say. But on the wet one, keep it clean. We need to keep it clean.
Okay.
Protect from the vapors, vaporizing. You can always put Vaseline petroleum gauze on top of it. We need to prevent it from the all the drainage and everything from vaporizing. So we need all that. Okay, I cannot find the word today. What's the name?
Okay.
Basically prevent it from losing the fluid.
Okay.
Yes. So, but for the lotion, that's for dry.
Okay, gotcha.
Mm-hmm. Okay, so let's go over some of the nursing implication for these skin reactions. Some of them we already mentioned, but let's go over it again.
Do you remember if they asked you anything about the hand-foot syndrome? I can't mention the other name, the erythrodysesthesia syndrome, whereby they have the tingling and in the soles and the palms.
Okay, hold on. Let me find it out because I think I forgot about that. What's the name again? One more time, sorry.
It's called the erythrodysesthesia, something like that syndrome. And she put AKA a hand, a foot syndrome. It's with the skin conditions. I mean, the skin changes.
Really? I don't think I see it in here. So maybe I didn't write it down. I'm not sure. Or maybe I forgot that. No, seriously, I cannot find it in my notes. So maybe I forgot to write it down. Can't find it. Sorry. Anything else I can help you with?
I'm trying to go through and see if there is anything that I want clarification on, because sometimes I feel like I got it, but then I don't got it.
All right.
So with hormone replacement, there is a high chance that they're going to either make the tumor bigger or smaller. You know?
Hormone replacement, either they make it bigger or the smaller. What are we talking about? One more time.
So it's like also to use to like treat, I believe, is it?
Treat.
It's used as to block the effects of the hormone and stop the growth of cancer cell.
Oh, really?
Yeah, but then I had sometimes it ends up like making it, no, actually not making it bigger. You get another cancer somewhere else.
So the hormone therapy, what I know about it is like, yeah, it can stop the growth of cancer cell. Um, but there are other hormones like corticosteroids, which used in the combination with other drugs, and it helps with the side effect.
Okay.
Hmm. But yes, it can stop the sex hormones can stop the growth of cancer cells. We have a table number 1514 on the book that will explain more about the hormones, I think.
I think I have the book.
Oh,
I
okay.
just got that small handbook for what's it called? Yeah, I just got the little pocket size,
Hmm. Okay.
my clinical companion, because someone told me it's better than the big book.
Hmm.
But then I can't like really find a lot of stuff because it doesn't go like, I don't know, maybe I got the wrong one. I'm not sure.
Okay.
So cardiovascular effects.
One more time. Sorry.
Cardiovascular effects
How you
of
spell that?
maybe like the therapies. So
Can you
cardiovascular, like a person who gets
can you type it down in the chat box so I know how to spell it?
vascular.
Oh, cardiovascular. Okay. So are we talking about the treatment right now, right? Side effects of the treatment on cardiovascular system?
Yeah.
Okay. So the treatment, the side effect on the cardiovascular system is dysrhythmia. And then because they can develop any kind of cardiovascular effect after the therapy. So we need to basically figure out what's their baseline with the echocardiogram. Um, and then we do it to find out the baseline, and then we do it periodically during the treatment. So if they have a CAD, then the patient is more vulnerable for the cardiovascular effects of the treatment. So they can also develop anemia. But do you know what we give them to treat anemia?
Apotin is apogen.
Mm-hmm. Yes, erythropoietin, or there's also a bigger name like erythropoiesis stimulating agent.
Okay.
Yeah.
Can you please explain what is meant by let me just write it. This one.
Okay. So, okay, let me pull those two topics and then I will go over it. No, sorry, copy of the treatment. Okay, so immunological surveillance. The only thing that I know about it is that chemotherapy suppresses the immune system. So we need to make sure that the person does not get an infection after the treatment or during the like when the treatment is going on. That's the most important concern about that. So when we talk about the tumor angiogenesis, so tumor angiogenesis is like when a cancer cell or tumor cell they make their own blood vessels.
Okay.
They increase in the size, and then their they make their like basically their own blood supply. So they what they also do is like first of all, when they get the blood supply, their size is gonna get bigger. They're gonna stress on the other surrounding cells, and then they're gonna steal their blood supplies as well by making new arteries and stuff like that. So it's very like it's very surprising. Like in our body, other cells they can most of them they cannot do that, but the tumor cell they can like they can make their own arteries to get the
Gotcha. Okay.
blood vessels basically, not only the arteries. So about the immuno surveillance, I think I'm still missing on that one. Oh yes. So the immunosurveillance is more about like finding the antigen. That's what we're talking about, right?
Yes.
Finding the antigen on the cancer cell, and then they target that. That's how they differentiate the immune. Sorry, that's how they differentiate which cell is the normal and which cell is abnormal. They look for the antigen on top of the cell, and if they see that antigen, then they're gonna attack that cell. But let me pull it up again. Okay, yeah. So the antigen that they look for is tumor associated antigen. The cancer cell, they also have the normal cell surface antigen, which is like same as the normal cells, but the cancer cells also have tumor associated antigens, and the immune cell look for those type of antigens. So the lymphocytes go and they detect the normal and abnormal cells, and whenever they see the abnormal cells, they attack only the abnormal cells. Are you following me?
Yeah. Yeah. Okay. I was writing it down. Sorry.
Okay. Okay. Yeah. So then there we have like multiple type of cells that can kill a cell or destroy a cell, and those are like cytotoxic T cells, natural killer cell, NK cells, and then macrophages, and then B cells. Actually, B cells produce antibodies that bind to the tumor cells.
Mhm.
That's how the B cell destroy the cell. Okay, so the escape, when we talk about the immunological surveillance and escape, so that cancer cells do escape from immune system because if they have a weak surface antigen, if the antigen that they have is not very strong, then they can sneak through the surveillance system and still grow.
Okay, and then what about the stages of cancer?
Yes, the stages of the cancer. Um, let me pull it up.
Like the initiation, promotion, and progression?
Yes, those are. Okay, this was the only chapter that I read the book for. I tried to read it for the other chapters, but this was the only. Um, this was the first lecture, and this was the only chapter that I read the book for. So the book went into really good detail about like initiation, progression, and all those stages. So the initiation is the first stage, and in this stage, the genetic structure mutation occur. You know, any changes in the DNA sequence that's initiate the development of cancer. Right? It could be inherited, it could be acquired with the carcinogens and stuff like that. But where's the other? I did not even write it down. That's very bad. Okay, so the first one was the initiation. The progression is the last one, and then promotion is the second one. Right?
Yes.
Okay. So in the promotion, like basically. Okay. So how do I explain it? And basically, if we don't take care of, you know, there are some promotion activities that can be reversible. If we do that, cancer might stop at wherever it is. If we continue doing that, it's gonna, you know, promotion means it's gonna grow bigger.
So that's
Yeah,
why I was confused about how it says carcinogens in initiation, but it also says it again in promotion. So I think in the first part, initiation, they just enter the cell, right?
so initiation is like the carcinogen in initiation. It could be like, you know, genetical. It could be like environmental, like, you know, the place there where a person is working. We can develop the carcinogen from there, or the viral carcinogens and stuff like that. That's gonna initiate. That's gonna alter the DNA of the cell. So they're gonna start the cancer. But in the promotion, yes, in the promotion, it also mentions some carcinogens. But if we avoid those carcinogens, the promotion stage can be stopped.
Okay.
Yeah. So like activities in the promotion that are reversible, like obesity, smoking, alcohol, dietary fat, unhealthy diet. So these can be reversible to prevent the cancer in the promotion stage. But some cancers are like, you know, you're getting old, so you're developing the chances like you might get a cancer later on. but it does not mean that every older person has a cancer,
Okay.
right?
Okay. Got it.
Yeah, and then in progression, it's basically characterized by increased growth rate of the tumor, how invasive it is, and how much it has metastasized to surrounding areas. So that's how we like, it's a final stage, and it's basically we look for the metastasized to other organs, um, and then we look for like invasiveness. Mhm. So the main sites that a cancer can metastasize to is lungs, brain, bone, liver, adrenal gland.
What about the defect cell proliferation and the defect cell differentiation?
Okay.
So I don't know if
Proliferation.
I got it right, but I feel like one of them, I don't know if I don't know. It's just confusing because it feels like with the differentiation it will be better, but no, it's getting bigger.
Okay, so proliferation, and then what else you said?
Differentiation.
Differentiation. Okay, let me find it out because I don't want to give you the false information. So I'm gonna look for my notes. Why can't I find it? Proliferation and differentiation. It seems like a long time I took this quiz.
So when did you have intermediate? Last time?
Last year.
Okay.
I still feel like it was a long time ago. Proliferation. Okay, so you want to go over proliferation and differentiation, right?
Yes.
Okay. It's not going to be this one. It's going to be the other one. Right here. Okay, so I'm looking for it, and I found it. Two major dysfunction. Okay, so okay, so cell proliferation is just basically like stem cell. When a stem cell is like, any type of stem cell is basically all the stem cells are same until a body's demand is increased about a certain cell, then the stem cell become that type of cell. You know, do you follow? Like our bone marrow produce all type of some stem cells.
Mm-hmm.
But if we need a red blood cell in our body, it's gonna become the red blood cell. If we need platelets in our body, it's gonna go become the platelet. So the stem cell is like undifferentiated cell.
Oh, okay. And then with differentiation, it's why they grow into cancer.
Yes, in differentiation, they are basically like, they grow into certain type of cell. They
Okay.
differentiate from each other. So why this is important? Because there the changes could occur when in the proliferation, like um, Another proliferation control mechanism. Okay, so the cancer cell grown in culture and are characterized by loss of contact and inhibition, growth on top of one another and on top of between the normal cells. So that's how, like, um, so in our body, we have cells that are dying, you know, apto- uh, apoptosis. That's
Mm-hmm.
like they're like death. That they're gonna die one day whenever like their cell degeneration occurs. They're gonna die, but we have new cells that are coming. So the new cells are gonna differentiate on based on that, and then
Okay.
the normal cells respect the boundaries and territories, but the cancer cells they do not respect other cells' boundaries or territories. So that when we talk about the contact inhibition, that's what we talk about like cancer cell, they have no regards of the cell boundaries.
Mm, okay. Okay, gotcha.
Mhm. The cancer cells respond differently than the normal cells. That's basically it. Okay. So do you need more clarification on this topic?
No, no, it was just confusing because I didn't know what it like. I was reading the words, but it was just not making sense.
Mhm.
Okay. And do you have anything on the older adults?
Yes. Give me one moment and I'm gonna pull it up. Okay. So do you have specific questions about it?
No, not really. I was because it's with the same quiz today.
Uh-huh. Why can't I open it? This is so weird. Okay, so finally got it. Um, so the older adult, it's like, they're older, so most of them they have the chronic illness, right? And,
Uh, so I was just like, I really don't know what to study from this
mm-hmm.
because it's it's basically like information that you already know,
Yeah, pretty
but I
much.
was
Uh-huh.
yeah, but I'm just like I don't like surprises and tests.
I understand. And also, okay, so if you have like any confusion or anything, because this is basically just as a, if you have any questions about any certain things, like anything, it does not mean like, smaller or bigger, so anything I will be able to clarify on that.
Mm, let's see. So the older someone grows, the more they're at risk for something.
Yes, because our cells are getting old, so we always have a risk to develop something new. um, so basically in this topic, it's more about like nursing management, nursing interventions, what are you going to do, how are you going to support them. That's the more important in this topic. But
And
basically,
also, what are some of the screenings that are more important that you saw too much of? You know,
it's,
like how they have like breast cancer screenings and the
Mhm.
prostate cancer
Right.
screening.
So, in cancer topic, I think there is an ATI book probably. They have something which tells you, like, from this stage, the cancer screening starts. From
Okay.
this stage, from this age, this screening is going to start. So you can like always follow up on that. Um, the breast cancer, colon cancer, and then we have the normal physical exam, um, and then we go over. And by this time, yeah, probably history also,
Okay.
and mostly not all of them, but mostly they also have like diabetes and then hypertension, high cholesterol. So these are the diseases which increases their risk factor for the major problems in the future. And then the aging, they also have their partners dying, their family members that they were close to, they're also dying. So that's also comes into the play.
Okay, and then for the like pneumococcal, they have to get a vaccine at 65 and every 10 years after.
Yes,
Okay.
starting from age 65.
Okay, so it's just things like that that
Mhm.
confuse me sometimes. And okay, so I think going through my notes, that's actually most of it
Mhm.
that I wanted information on because God, I really it's confusing sometimes.
Yeah, and sometimes it's like it's a lot of chapters to read. It's a lot of PowerPoints and the PDF, and then we also have the ATA book. So it's kind of like overwhelming information sometimes. Um, I don't know. I heard from a tutor, not about the med search, but the mental health, that he said that he was writing all the information, taking notes, even the PowerPoint, even if he's writing this everything same on by himself with his own hand, you know, typing it or like writing it, it would help him. For me, I was not doing that in the beginning, but then I, for some of the topics, I start doing that, and it was actually helpful.
That's what I did from actually mental health too because it was hard. So I had to read the textbook. I
Mm-hmm.
made sure I read the textbook first because that's where you get most of the information. Then I would go over to ATI and
Mm-hmm.
read that,
Mm-hmm.
10 pause.
Mm-hmm.
Then I would do the success book. Then I would do the ATI quizzes, and then I'll be ready for my quiz. And I feel like that was helpful other than just basically going off of the lecture because some information that
Mm-hmm.
is not usually focused on lectures I would have.
Yes. Some of the teachers are very like they explain most of the stuff when they do the lecture. uh, it's also present in a PowerPoint or PDF version or whatever they gave us to study for, but it's not everything. You always have to go back to any kind of book and get the more depth information from the book and then go from there.
So you're in OB right now?
Yes, I am an OB.
How is that one?
That one, so far, it's okay. It's just that when I say about like reading a book, the OB is the one that I need to read the book really, really good.
Oh, really?
Yeah, yeah. Because everything, like, it's a lot of information. It's a very new information because everything changes in pregnancy and with the fetal, and then the vital signs of the child, newborn. That's the addition, and we have two patients in the OB, like mom and the baby. So everything, all the information that we have is very different from the med surg. So they cannot explain everything during the lecture. So that's why I have to go back and read the book.
Okay.
Yeah, and I barely got my book, like barely.
Is there like a lot of chapters like the others, like all these others? Because sometimes we've had like 3 chapters.
Mm-hmm.
Then you have to read the actual book.
3 to 4 chapters. They're like that's the average.
Oh my God.
I know. And the med surg, it was the same, like 3 to 4 chapters, and so I could never get it done in med surg.
Oh my God. Anyway.
I know it's too much information, so I was mostly focusing on like going over the information over and over again from my notes, and then I would read the ATI book before the quiz. Like I was just reviewing, using that book as a review.
And like, who did you have? When did you have your clinical?
For the med surg.
Yeah.
The clinicals were, I was also working as a LVN, so that I used that as my clinical, but I still had a clinical on Tuesday. I forgot the professor's name, but I had the theory with the Dr. Poyamada.
No, I have a Professor Chai. I have it on Thursday, that whole day.
Yes,
That's
totally. I know.
I had I'm also an LVN, and I had already put my job on hold actually. So
Really?
I just told them I'm not gonna be able to do school
Mm-hmm.
and work at the same time because it was a skilled nursing facility, so they usually give you like a lot of more patients, like yeah, whereby sometimes I had like 60, you know.
I know.
It was overwhelming. So I told them I need to concentrate on school. And
Right.
then when Corona happened, and then they're like, "Oh, you need hours," and I'm like, "Okay, what am I going to do now?" You know.
Mm-hmm.
But I'm I'm good with right now. Telehealth kind of helps, but then I think it'll pay off. But if this happens more and more, I think I'll go back to work and at least work 1 day a week, just get the hours.
Yes, that's true because they need the 12-hour in a week. So actually, I wasn't working I was only working part-time before the corona, before the COVID. But then they were like, okay, so we need people. Nobody can come over here anymore. We cannot exchange people. So we need more nurses over here. So they put me 40 hours per week,
Mm.
and I'm still working as a 40-hour LVN.
How do you do it and then do school?
Um, yeah, it's I just like juggling. That's the best word that I can use right now. Um, Basically, I work from 12 to 8, so I do my homework in the morning and in the evening when I come back from work.
Okay.
So that's why I make my notes, and then sometimes I take it over there, and sometimes I use my phone to study if I have any time and at work to, like, um, any free time. I try to utilize as much as I can.
I usually also make notes based on what the professor emphasized on in class.
Mm-hmm.
And then I record myself saying
Right.
them out.
Uh-huh.
And then usually when I'm going like shopping, driving somewhere, I just put that on.
Are you
So
an audio learner or the?
yeah, like audio, it kind of helps, but it's also visual. But then, we have places where you have to go do something. So the notes on audio is kind of helpful.
Mhm.
Yes, so that's how I kind of like even sometimes in the morning when I wake up and I just play the notes. So it just like helps repeat what I think is gonna be more important. But then sometimes it doesn't work, and I'm like, okay,
Mhm.
because I'm distracted.
Right. Yeah, it's very hard with the work and everything, but um, and now the clinicals are online as well, so
Yeah.
that's another factor.
Anyway, thank you very much.
I hope it
Hope
was
Valentine
helpful.
goes for me, but I think I'll be here Friday again.
Yes, I'll see you Friday.
Thank you.
You're welcome.
Bye.
Bye bye. Take care. Good luck
Okay.
on the quiz.
Thank you. Thank you.
Bye bye. Your turn.
in